Let me move back to the question about ESRD, code status, chronic exclusion. Bill, do you want to make any comments generally on how the payers are thinking about kind of looking across different risk factors and so on? And then do any of our clinical advisors or others have comments on the difference in the patient pathway or severity for patients with those conditions?
Well, the only comment I was going to make before I turn it over to the experts here is that there's a difference between exclusion and a risk factor. So somebody who's on dialysis will be excluded. Somebody with, stage 2 renal failure would be a risk factor. So I just want to make sure that's clear to everybody listening that, things that are, pretty high risk we're going to exclude, but otherwise would be just a risk factor.
And in that context, for different types of renal insufficiency, to take that as an example, in your mind, is that something where it absolutely needs to be excluded, that patient, because the care delivery pathway is so different from every other PCI, or is that something that could be risk adjusted, so to speak, where the historical cost would be higher because that patient requires some more intensive treatment, but that's something that could be adjusted? I'm looking to the physician that asked the question to see if he has a perspective on that. There's a microphone right behind you.
The comment was related to the slide that's on display, which says end-stage renal disease as an exclusion. My comment or suggestion is that it should take into account end stage as in stage 3 or 4 renal insufficiency.
I see.
Where doing the procedure would certainly put the patient on dialysis, with that not being taken as a complication of the procedure or taken as an adverse outcome. This would be because of the risk. This is a known entity that's going to happen. So it should probably, the wording should be renal insufficiency rather than end-stage renal disease, which by definition qualifies people on dialysis only.
Great. Thank you for that clarification. That's very helpful.
I'm guessing the level of chronic renal injury is not coded in the bills, which is probably going to make it problematic. And also, isn't chronic renal insufficiency pretty common in this patient population? If we were to exclude anyone with chronic renal insufficiency, we'd have a pretty small group.
Yeah, I mean, well, it gets, now I'm talking about as an internist. I mean, when you start getting to a GFR 20 or 25, there's a difference between that and say 30, 35. So I think we'd have to look at that and see what we can do with that.
Just in general, the notes that we're taking in each of these, the payers will go back and look at some of the historical data, the percent of cases that have these, what the historical costs are. Does it make sense to expand the exclusion list, add them to risk adjusters? So that's the sort of follow-up analysis that will happen. And the kind of revised details of this will all be posted for folks to be able to see as well. So we are writing these down just in case you're wondering how the comments are being incorporated and the feedback is being incorporated.
So as a comment, we need to be very careful also when speaking of staged procedures that we're not overlapping with AMI measures, because many times a staged procedure happens because of an acute lesion, and then we bring patients back for what is stable but critical disease. And so I think the question from the other video conference site initially included what happens to those folks who were previously in an episode for AMI but have also a critical stable lesion that needs to be treated as well. So this is where these episodes overlap, and I want to see what your comments are about how those episode overlaps are going to play out in the future.
Great, thank you for that question. And I was just talking to some of our clinical advisors here who have made similar comments as well. You'll see on page 34 on some of the different risk factors listed, for example, the MI, renal insufficiency, the goal really is to go look at some of the historical costs and patterns to see if there are additional exclusions that need to be applied, or if historical data can help apply risk adjustments and others such that the expected cost of a PCI after an MI, the STEMI and STEMIs we discussed before, would be much higher than a PCI for a patient with stable angina, for example. The goal of this is to find either quality metrics that really are gold standards of care that would be very helpful to ensuring that when you have an incentive model in place that there's that high quality care still coming first, or in many episodes they're just utilization and other metrics that are very helpful actually for the physicians and providers to be able to see. So in some of the other episodes we've been contemplating whether the percent of patients with an acute exacerbation of COPD and asthma, what percent of those patients actually followed up with the PCP within the 14 days. Those are things like that that may be helpful to the providers for the episode just to understand what's happening to their patients. So that is the goal of what this is. You'll see 7 example or starting quality and utilization metrics here. The first one is the percent of non-acute patients on beta blockers in the 90 days prior to procedure, the percent of patients undergoing nuclear imaging studies prior to the procedure, the percent of patients that are having multiple PCI procedures within the 30 days, percent of patients with post-op hemorrhage, percent of patients on beta blockers, antiplatelets, and statins in the 30 days following the procedure, tracking the incidence of adverse events, whether that's a stroke, MI, etc. And then the last one was really to find some way to, as a helpful mechanism to providers to understand what percent of patients that have had a PCI are seeing their either outpatient PCP or cardiologist, whoever is helping to manage that care to really manage readmissions and so on. Bill has a comment here, I think.
So as you look at these are not accountability measures. There are no necessarily on these performance thresholds. I mean, some of them, like the beta blockers, we might have one to qualify for gain sharing. Some of the others that deal with things like multiple procedures or the nuclear studies is more of a normative thing to give an understanding of where everybody is compared to everybody else in the system. So it's more informational than it is an accountability or an expectation of performance to be a part of gain sharing.
How will you account for patients who are given prescriptions, do not fill them, but are supplied with samples?
And I heard the question is how would you account for patients where a physician writes a prescription for that patient, but the patient never goes to fill the script?
As well as how do you account for samples being given to the patient for a patient who says, I can't get my FN or I can't get my Plavix, and they're given samples. How will that be? How will you be given credit for that?
Right, okay.
Comment from Fayetteville. So another quality measure that you might find is the number of nuclear stress tests performed post-PCI for non-culprit lesions, which could show you whether or not patients or providers are following evidence-based medicine, particularly for acute MI, and then following lesion severity with making sure that there's ischemia prior to repeating a second vessel intervention. And so your nuclear procedure being pre-procedure may also want to include post-intervention nuclear for non-culprit lesions.
And on that one, do folks, just a clarifying question on that, do folks have a perspective that there is variation on that in the state post-procedure as well?
I think what we're also trying to refer is there an incentive for evaluating a lesion that's required treatment or not, whether it be a stress test or something called an FFR, that's a cardiac cath-based. Right now there's no billing code or reimbursement for doing that. That's something, will that be incorporated, which could help physicians give an incentive doing evidence-based medicine on that.
And what would be the implication in a PCI episode? Would that help with appropriateness of the PCI? Would that help?
Oh, absolutely. Absolutely.
Great. Okay. Thank you for those 2 comments.
Claims data are always easier to get than having people put data in that they documented the discharge. Beta blockers, thank goodness, are relatively inexpensive now, are not necessarily sample dependent. You start getting into the issue of Plavix and aspirin, and again, there you may have people getting additional issues with accessibility, but in this program, everyone will be insured. It'll be a Medicaid patient or a Blue Cross patient. They should have coverage for the drugs, so it shouldn't be a problem in terms of getting access. And then the question is going to be the patient adherence factor, And as we move forward, everyone should be in a relatively similar situation. And some systems are getting more aggressive in terms of care management at discharge. So again, we don't expect 100% adherence, 100% compliance. We'll have some threshold level. So, if you're at the 75, 80% range, 90% range, that will pick a number. If you're at the 50% range, then there's something either very unusual about your patient population or perhaps your discharge processes could be improved.
What follows here is Arkansas Medicaid and also Arkansas Blue Cross Blue Shield data over the course of 1 year for 2011 for Medicaid, and you can see the time frame for the Arkansas Blue Cross data. So page 39 for Medicaid shows the average cost historically for 2011 of PCIs for patients STEMI and STEMI unstable angina, and you can see the two others. And you can also see the breakdown by how much of that cost on average was inpatient versus outpatient versus the professional fees for the physicians and pharmacy. Yeah, and Bill is pointing out that the data that you're seeing now is not risk adjusted. This is just so we can look at historical things to have this discussion. Page 40 is the same exact chart, but for Arkansas Blue Cross. And so you can see the relative shape between STEMI and STEMIs look similar. However, the mix between the different types of costs, so Blue Cross, the inpatient component on average is much more of the cost than the Medicaid episodes. On pages 41 and 42, you'll see the cost variation curves for each of the performing providers for the PCIs. On page 41 is the curve, again, not risk adjusted, for Arkansas Medicaid. And page 42 is the same curve, but for Arkansas Blue Cross Blue Shield. And so you can see what the shape of the two curves look like. Then on page 43 and 44, these two charts show the distribution of episodes across the various performing providers. So you'll see on page 43 for Medicaid, in 2011 there were 64 providers for PCI episodes. 40 of those had very small Medicaid volume, less than 5 episodes per year, and 24 of those providers had at least 5 episodes per year, and those 24 providers accounted for 82% of the episodes for Medicaid over the course of a year. Page 44 shows the same chart for Arkansas Blue Cross, where 84 out of the 105 providers accounted for about 95% of the volume for PCIs for that year.